Alright class, we're going to pick up where we left off in our PowerPoint from on Tuesday. So the first pathology we'll cover is the MCL sprain. So as we see here, the etiology for both MCL and LCL sprains are going to be forces that come either from the outside or the inside. So for an MCL, you got to remember that it has to be a valgus force, meaning that the force comes from outside of the knee towards the inside of the knee. And for the LCL, the lateral collateral ligament, it would be the opposite. It would be a force coming from the inside going outward. There's also the twisting motion, or you could have a combination of both twisting and a valgus or varus force. And then we have signs and symptoms. You can grade the symptoms based on. The symptoms would be graded. Would give you a grade from 1 to 3, from partial tear to a complete rupture. You'd have pain on passive stretch, point tenderness, and then you can have minimum to moderate swelling. So for management, the first thing you got to do is rule out a fracture and dislocation, depending on how the injury occurred. You're going to do RICE for 24 to 72 hours, depending on severity. Usually if there's a lot of pain with weight bearing, you want to give crutches. You can also have an immobilizer so that they're not bending or fully extending their knee. And of course you want to follow up with ice and then start increasing range of motion and strength. As far as return to play, that's going to be determined by how functional they are, how much strength they have, and then also just mentally how ready they are. And you can also provide bracing and taping to provide a little bit of support. Now we'll move on to ACL and PCL sprains. Here we see the anterior and posterior forces that create the tears or the ruptures. So anterior, as you see on the left here, if you have the femur, which is this one translating anteriorly, that would create an ACL sprain. And if you'd have a posterior force pushing against the tibia, then you would have a PCL sprain. So as far as the etiology for an ACL, this is the anterior cruciate ligament. You have to remember that the most dangerous position for the ACL, or where it's most likely to get injured, is when the tibia is externally rotated and you also add a valgus force at the knee. An ACL tear can also result of hyperextension. You actually see that a lot if someone gets hit from the front and you get full hyperextension of the knee, or if they land with their knee completely locked out. You can also get an ACL tear that way as well. And then just if you can remember, typically ACL, non-contact ACL injuries typically happen more in females than they do in males. So some other factors to consider are the conditioning status of the athlete, skill acquisition, how far along they are with learning their skill, their playing style, equipment, and preparation time. So like I've mentioned a lot of times, anytime you have an injury to a joint or a muscle, anything like that, there could be some secondary injuries. So you can, when you're talking about tibia being externally rotated and a valgus force involved as well, you can also have damage to the meniscus, the joint capsule, and the MCL. Some signs and symptoms: the athlete will usually say they felt a pop or they heard a pop. Then as far as their special test, you'll have a positive anterior drawer and Lockman's. There will be a lot of swelling along the joint line. And then there's other ACL tests that we won't really cover that may also be positive. As far as the management, Just like with any other sprain or strain, you're going to use rice. And if they can't bear weight, use crutches. And then depending on what the MRI tells you, as far as the severity of the injury, they may require arthroscopy, or a small surgery where they just need to repair the ligament. And it says without surgery, degeneration may result. So if there's an athlete that really does not want to get surgery, but they want to continue to participate in sports, the problem with that is that the joint is going to be a lot more unstable, and then the tibia and femur are going to be pretty much hitting each other a lot more. There's going to be a lot less stability in there. So it says surgery may involve joint reconstruction with grafts. So a very common surgery or reconstruction is with your own patellar tendon. Another option may be an allograft, which would mean that the tendon that they're using comes from a cadaver. So once you've done the surgery and you've gone through rehab, like it says here, it'll be 4 to 6 months of rehab, but for you to return, or for the athlete to return to full participation, they're going to require about 9 months. So here are some pictures of what the arthroscopy would look like. On the left you see a normal ACL, on the right you see the torn ACL. So for the posterior cruciate ligament, the etiology, so the most riskiest position for that is 90 degrees of flexion. Then you fall on a bent knee, so the tibia being pushed posteriorly. And again, they can feel a pop, tenderness, and relatively little swelling in the popliteal fossa. And we covered that in class. I showed you guys where the popliteal fossa was, and that's behind the knee. So it says management, non-operative rehab of grade 1 and grade 2. Once it's ruptured, though, they do have to go through surgery. Next portion of pathologies are meniscal lesions. So for meniscus, you're going to have some of the same etiologies as for like an ACL. The medial meniscus says it's more commonly injured due to the ligamentous attachments and decreased mobility. So I mentioned that the MCL is intracapsular, so it attaches to the joint capsule, but it also has fibers that attach to the it attaches to the joint capsule. And so anytime you have a valgus force and a rotary force, so anytime you're twisting, you can injure this ligament. And so for signs and symptoms, effusion develops over 2 or 3 days, joint line pain. One of the major signs and symptoms is locking or giving way of the knee. So a lot of times patients will say that their knee clicks and that it locks up on them whenever they're sitting and they begin to stand up. So here we have some pictures of tears to the meniscus. And here's some just pictures of what lesions on the meniscus could look like. This one here is typically called a bucket handle tear, and it's just a longitudinal tear along the medial meniscus. So for management, you want to refer to a specialist, and sometimes it could be where the athlete's knee completely locks up and they can't fully extend it. So that's when you want to refer immediately. But if it's something where they're in some pain but they can put some weight or they can ambulate on their own, then they don't really need to go to urgent care or anything like that. They can just set up an appointment with their orthopedic specialist. So like I mentioned in class, Meniscectomy means they remove part of the meniscus, and they can be partial weight bearing and quick return to activity, whereas if they repair the meniscus, that requires immobilization and gradual return to activity over the course of 12 weeks. So the next portion we'll cover is the knee plica, and doesn't happen to everyone, or not everyone has a plica in their knee. It's a thickened fold of synovial membrane along the joint line of the knee, and this can present itself like a meniscal tear or meniscal injury. But when testing and doing a lot of the special tests, they don't come up like they normally do for meniscus tear. And for example, some people do have a plica, but they don't have any pain or swelling, and that's fine. They don't have to do anything about it. But when it becomes irritated and starts affecting their performance, that's when they have to refer, and they may potentially have to remove that portion of the synovial membrane. There's also just incidences where there could be loose bodies within the knee. It says possibly stem from osteochondritis dissecans, meniscal fragments, synovial tissue, or cruciate ligament. So sometimes there could be portions of the meniscus, some of the ligaments that get completely torn off. There might be small little pieces, and those can get stuck between the tibia and femur, and cause a locking sensation and a lot of pain. Okay, the next portion I'll cover are joint contusions. So anytime you sustain a contusion, it's usually going to happen from falling or getting hit along the joint. It says lingering pain and difficulty usage to the area, may notice swelling or discoloration. And if it's a bruise to the bone, you're going to be able to see it in an MRI. And this is just, very painful. It can last for months sometimes. And with x-rays, obviously it won't show a fracture, but with an MRI it'll show this lighting up of the imaging, and that'll kind of tell us that there's some damage to the bone. So the etiology is blow to the muscles crossing the joint. Signs and symptoms present as knee sprain. There could be a loss of function. Alright, we're going to skip forward to patella subluxation and dislocation. So the etiology is going to be deceleration with simultaneous cutting in opposite direction. So there's a valgus force at the knee. And sometimes it could just be a forceful knee flexion that can also dislocate the patella. So the one thing to remember that when a patella fully dislocates, it's probably going to dislocate laterally. So some of the signs and symptoms that you're going to see are pain and swelling, restricted range of motion. With the dislocation, there's going to be a loss of function. So they're going to be pretty much stuck in a flexed position. There's going to be sharp pain. So for management, if there's really no way to reduce the dislocation, you have to splint as it lies. If you can help them extend their knee, and then sometimes that will help relocate the patella. Alright, the last slide, or the last couple of slides I want to cover are for Osgood-Schlatter disease and Larsen-Johansson disease. Osgood-Schlatter's is just an apophysitis occurring at the tibial tubercle. And the Larsen-Johansson is a result of excessive pulling on the inferior pole of the patella. So this picture here will kind of show you the difference. Larsen-Johansson happens at the inferior pole of the patella, whereas Osgood-Schlatter's happens on the tibial tuberosity down here. That's going to be the major difference. And this is going to be a pathology that mostly happens to adolescents. It happens as bones are developing, and there's a lot of stress on those areas. So please make sure that you remember that and the difference between these two pathologies. The rest of the slides you guys can just cover. If you have any questions, please let me know. But those are the main things that I wanted to touch on, and that are probably going to be on the quiz.